Okay, excellent. Hi, everybody. My name is Rachel Mcrickard. I'm the CEO and founder of Motivo Health. I'm also a licensed marriage and family therapist. We have been partnering for a couple of years now with Elevance Health, formerly formerly Anthem, to lead some conversations around racial equity, around cultural humility. This is following up on that series. We've been doing these quarterly with a collection of expert healthcare professionals, either from behavioral health or just strict healthcare, around these topics. And today our session is on the intersection of race and disability. We're so proud to partner with Elevance. They've been very committed to these conversations and have helped us find some really fantastic speakers to speak to these topics. So I'm excited to pass things over to Dr. Carla Smith, who's going to facilitate today's discussion. Thank you so much for being here. Just a couple of housekeeping issues. The chat is open. You are welcome to share where you're calling in from and a little bit about what you do in the chat if you would like to. You're welcome to use the Q&A or the chat to ask a question. And if we have time, we'll post those to the panelists towards the end. And then lastly, if you're here in search of continuing education credits, just stay for the whole session and we will give you the link to the survey at the end. So let's dive in. I'm going to pass things over to Dr. Carla Smith, and thanks for being here.
Yes, thank you so much, Rachel. I am Dr. Carla Smith. I am a licensed clinical social worker and licensed marriage and family therapist, as well as the chief clinical officer at Motivo. This has been a relationship between Motivo and Elevance Health that has really, allowed us to engage in some important conversations. And this is actually a part two to a conversation that we started a couple of months ago, and where we were asked to kind of, continue to have deeper conversations, especially here at this intersection and understanding intersectionality as it relates to race and disability. I'm so excited to be here with our three panelists. I'm going to have them introduce themselves as well as where they're calling in from and tell us about the work that they do. So Cynthia, Dr. Overton, I will have you go ahead and start.
Okay, well, thank you so much for that introduction. My name is Cynthia Overton, and I am joining you from New York City. I actually live in Silver Spring, Maryland most of the time, but I'm in New York now. I'm at a conference, but I once saw somebody actually give a presentation while she was about to catch a flight in the airport. So I figured I could step away from the conference and join you here. So I was fortunate enough to be on the initial panel, which was amazing. Let me just start off by saying I'm really looking forward to this conversation. And I hope that you all will feel comfortable asking the questions that you might not really feel comfortable asking in other settings, because that's what we're here for. We're here to learn, right? So in New York right now, I work for an organization called the KPOR Center, which is a racial justice organization focused on diversity and tech. But I actually started my career really in the disability space many years ago. Started in accessible technology and assistive technology for people with disabilities. My dissertation looked at how people who are blind use technology to engage with their learning environment. Since then, I've done a bunch of disability policy work. I've also done work in the areas of knowledge translation for research surrounding spinal cord injury, traumatic brain injury, and burn injury. So it's just a real pleasure to be here with you today, and I'm really looking forward to our conversation.
Thank you, Cynthia. Your work is so important, and I can't wait to hear more about that, as well as the ways that we can learn, from you and your experiences. Before I get to our other two panelists, I'm going to send it on over to Meryl, who is my co-facilitator here. So happy to see you, Meryl. Introduce yourself and, tell us what's up with you.
Hi, everyone. This is called Grace Under Fire, but not so graceful, as Zoom did not work for the last 40 minutes of trying. So I appreciate everybody just kicking off, and it's great to see you, and I will regroup quickly. I'm Meryl Friedman. Thank you to all the participants and everybody who has joined us today. I was sitting in the participant room with you for a while as well. Good to see you there. And we are always so excited to be working with Motivo, and then just, I mean, these panelists, y'all just wait till you hear the discussion. I agree with Cynthia. I love the way she said that. I hope you feel comfortable. We really want to create a safe space for everybody to ask questions and weigh in. Rachel and Dr. Carla already teed up our partnership, Elevance Health, formerly Anthem. I did hear Rachel slip up there. That was fun. You know, we have really appreciated the partnership. The change in our name is similar to why, you know, we host these conversations with everybody, is really talking about our evolution as a health organization to, you know, be a more trusted health partner and looking very much well beyond traditional healthcare. On that note, I have a white woman. I have curly, very salty, no real pepper in there anymore hair. I'm wearing a black shirt. My pronouns are she and her. And I have sort of a blurry virtual background behind me. We hope that throughout the evolution of this series and these discussions, you're hearing us, you know, say part 2. But really what we are going to do is we're going to be really inclusive. If you aren't at part 1, it doesn't really matter, right? Be with us here. This is just a continuation. We're going to dig deeper. If you need us to back up and cover anything, we're all very happy to do that. We even have a new speaker with us. So you're going to hear his introduction. So I won't do that for him. We are going to be very inclusive. We always want to be very inclusive. When we talk about disabilities, we're talking about mental health disabilities, physical disabilities, intellectual and developmental disabilities, and people who encounter disability as they age. It's all a very different experience. Everybody's experience is very unique. We're going to talk about intersectionality, and all of this is the, you know, that intersection between race and disability. And so join us, bring your questions, make us think. No softballs. We look forward to furthering discussion. Typically, if you've been with us before, you will know that Dr. Carla or even our colleague, Dr. Malloy, who have led these. Today's a little bit of a special occasion because Carla is letting me pal around with her a little bit, and I'm going to tag on, and we're all going to talk together and co-facilitate and just have a really casual conversation. So enough there. Thank you. And we will go back to introductions. So are we turning it over to Tawara?
Yes, good afternoon, everyone. Really pleased to be here again. I was part of the first one. So I'll start with my description. I self-identify as African-American, cis woman. I am coming to you from Washington, D.C., the District of Columbia, my hometown and wannabe state. That's a hint, hint. We're wannabe state. My physical description, have deep, rich brown skin. I wear my hair natural and twist. I'm wearing glasses, my other glasses, because I can't find the ones I typically wear. And I have on I don't know the sheet, but everything matches. Okay, I'll just say that, and picked up a color in my necklace. And again, my work is at Georgetown University. I direct the National Center for Cultural Competence, as well as the University Center for Excellence in Developmental Disabilities. I've been there for a while, so I'm on the later stage of my academic and professional career. So that is my my introduction. Very happy to be here to share and exchange and learn from this group that's been assembled.
Thank you so much, Tawara. I can't wait to hear more about your work as well. Dr. Marco, are you able to go ahead and, oh, there we go. Go ahead and introduce yourself for us.
Yes, hi. I'm really honored to be here, and my name is Rex Marco, and I'm an orthopedic surgeon who's has specialty training in reconstructive spine surgery and musculoskeletal oncology. and my social location is that I am an Asian male, cisgender, heterosexual father of 4, divorced. I was born in the land of the Tongva and currently reside in the land of the Akokisa, known as Houston, Texas. And my pronouns are he, him, his. I was raised, my grandfather was a Presbyterian minister, and those are my potential privilege biases, and I'm really happy that I'm here.
Yes, we're happy you're here too. Can't wait to hear more also about your work and experiences, Dr. Marco, as well. So I'm gonna actually.
I forgot something. I am currently living with C3 quadriplegia. Forgot about that.
Thank you. Thank you so much.
You just made me realize too that I failed to mention as well that I also identify with disability. I have ADD. And so hopefully you will experience some of that throughout the next 90 minutes.
Thank you both so much. I think my internet is going in and out. So if I do drop off, I will be right back. So yes, thank you all for introducing yourselves. We're actually going to kind of start and jump in about, why this conversation is important. We talked about why this conversation was important to Motivo and Elevance Health as we continue to engage in important conversations about social location and in this case intersectionality, but I'd really love to hear and just kind of slow us down around why this conversation is important to all of you. As a mental health provider and a person who experiences anxiety, I think that there's just so much around, the places where we don't get a chance to engage in the human, experience of disability as well as race. We're talking about people on the other ends of, this conversation, and we're talking to people on the other end of this screen. So I'd really love to just personalize it and make it clear why not only this is important in our work, but also why this is important to us personally, so that we can really just, found the conversation there. So, Tawara, I'd love for you to start. Why are, conversations at the intersection of race and disability specifically important for you?
It is my work. It is my passion. I have focused on this for a very long time. I would say that probably initially, dating back to my earlier days at when I first came to Georgetown University Center for Excellence in Developmental Disabilities, that the focus was largely disability without recognizing and acknowledging and responding to the within group differences among people who experience disabilities based on race, ethnicity, language spoken, and other, I would say, other identities. And so being able to engage in that conversation with, in particular with healthcare professionals, is really key and critical. My work first started with early intervention. And I can't tell you how many times when we did developmental screening and assessment for young children, the parents would tell us, well, we went to the doctor, or we went to our healthcare provider, and they said, he'll grow out of it, or she'll grow out of it. And that was way back in the day. And unfortunately, we still hear the same stories. And we particularly see those disparities among young children and who are from specific racial and ethnic groups other than non-Hispanic white. And so I think that we have to look at the nexus of race, ethnicity, and disability so that we can really explore the multiple experiences, the multiple cultural identities, and issues of intersectionality that impact many people who reside in this country.
Thank you so much. I think, the importance of being able to look at the experiences of, not only ourselves, but outside of ourselves is such, important work. And I think a lot of what we're going to talk about today is around, the self-awareness that then extends outside of us. So what can we do, for ourselves that also helps in the ways that we care for other people? Dr. Marco, what about you? Why is this conversation important for you?
Well, this is a difficult answer because I was so naive about this topic, and even before my injury, I didn't understand that there was something called ableism, and after my injury, experiencing ableism in very sad ways has helped me understand how when others are privileged blind, including myself, that we can harm other people. And what really helped me is my mindfulness meditation teacher certification program. We have a 6 months of training in DEIA, with the A standing for accessibility, and we learned so much. And I learned that I really didn't have an identity of my own. It was really, I grew up identifying as a white male, which is very strange, and it might sound strange to you, but it sounds strange to me now because I'm embarrassed by that now, because I had so much naivete around the harm, the cultural harms and the racial harms and national harms that occur. But taking a course like that has really opened my eyes, and knowing that I will be leading more diverse groups, and also now identifying with a disability, it's really important for me to do this work.
Thank you so much for sharing that. It's personal experiences. They always say, the power of personal experience is what drives change, and it's what drives meaningful conversation. And I think the last 3 minutes of listening to you share and share so honestly is a webinar in itself. And will inform a lot of what we talk about. So thank you. There's so much more to unpack there. I know Dr. Carla is probably preparing questions in her head like this. So be warned, this will be great. Cynthia, do you want to share a little bit as well? I should refer to you as Dr. Overton.
I think you should refer to me as Cynthia, and I would love to share. Thank you. So for me, I think that it's just very highly personal. I mean, being a person with a disability and being Black and experiencing those intersecting identities can be exhausting sometimes. It's an issue I think that a lot of people really don't feel comfortable discussing, whether it is ableism or racism. The fact of the matter is that, especially as I think about kind of like the racial bias in this country, it just runs so deep and it makes people very uncomfortable, and nobody wants to talk about it, even though there are people who have to experience it every single moment of their life. I think about kind of expectations and falling into categories and people trying to categorize you in certain ways. And I think that can be very difficult, especially as I think about the health care system. I'll even give you an example. I remember once when I was in the hospital, this was when I was at the University of Michigan pursuing my PhD. And I told the physician that I was a doctoral student, and I was at the University of Michigan Hospital, and I love the University of Michigan, so I'm not trying to bash U of M. But I found it very interesting because she asked if I was a doctoral student at a neighboring university, which is a fine university, but it was no University of Michigan. It's like, why would I don't understand. Well, actually, I do understand. And my point is that I think about that very innocent question that she had, right? And it made me think about, well, what other decisions is she making about me just based on my appearance, you know, how I look? So for me, it's very important, as I think particularly about healthcare and other ways that Black folks, that people with disabilities are served, to really have these conversations to acknowledge and try to kind of remove these preconceived notions that we might have about folks. So that's why I'm really interested in these kinds of conversations.
Thank you so much. I even think that, you know, for us to really be able to, you know, humanize the experience also says that, you know, this is something that we continue to learn, you know, kind of together, and to even make sense of, you know, taking note of where we can, you know, be better and do better. And so I want to, you know, just kind of note and identify that we had an oversight in, you know, not turning on the closed captioning before the panel started, which definitely is something that, you know, the ability to have the oversight is a privilege that we want to make sure that we are not only aware of, but that we make sense of how to not do this again. And so, you know, I really hope that we are able to at least on the back end have a maybe even have a transcription. But if we can't fix it this time, it is definitely appreciated that we're able to acknowledge that this is something that we need to get right moving forward. So, you know, to the point around, you know, bias and privilege and places where we have, you know, blind spots and where we need to do a considerable amount of work, not just when it comes to race, but also disabilities and the intersections of both. I really would like for us to start with this conversation of language and meaning making. The one thing that I think is a blocker and a barrier oftentimes is, you know, a few things actually. One is, you know, where can we possibly go wrong when it not only, you know, comes to our privileges, like I said, the blind spots, the places where we don't necessarily, where we have the privilege to not think about it, right? But also in our language, and that there are times where, you know, there's some intimidation of, you know, am I going to say the right thing? And if I say the wrong thing or do something that is offensive to somebody, how do I engage in a way that is authentic, but also puts the onus on me to make it better, not only in that moment, but also to learn from that experience. So, you know, Meryl and I had, you know, a conversation about language. And so I'd really love, and Cynthia, I'll start with you. What are some examples of language that tends to marginalize people with disabilities, often used by broader society? We kind of talked about, you know, even just using the term disability, people with disabilities. Let's start that conversation now.
Yeah, so thank you so much. So I don't want to speak as specifically to intentions, but I can speak to language that, you know, kind of makes my ears perk when I hear it. So, you know, oftentimes I'll hear phrases like differently abled or handicapable. And I can say that within my kind of circle of friends who have disabilities, we kind of just say, oh, that's adorable, you know, or we chuckle. That's really not necessary in terms of trying to, I think that maybe people think I don't know what people are thinking, to tell you the truth. I say person with a disability because I try to train myself to use the person first. So person with a disability, but a lot of my friends who have disabilities actually just like and prefer the term disabled person. Or I am disabled. I think that for me, what I try to do is center the individual to kind of see what language the person that I am engaging with prefers and take their lead. You know, like they say, the platinum rule, people treat people like they want to be treated. But I will also say that within a different context, I can certainly understand and appreciate the experience of people who may not necessarily say things, I'll just say right the first time, but keep trying. And I think that it's really important to the extent that when we see people who are trying to be supportive and extend grace.
You know, I think, and Cynthia, you and I, we've all talked about, you know, and we kind of call them the cutesy terms, like you said, handy capable. But I think, you know, there are terms. So we talk about, right, like people first and identity first, and everybody's got a preference. And I think part of having this discussion, and even in our prep discussions, you know, we say we've got to listen and hear, you know, how people identify and how they, you know, want to be referred to. You know, but we typically start with person first and people first language because it's a starting place. But identity first language is very important. And it is very important to people who, you know, refer to themselves as disabled, right? Or, you know, refer to themselves as autistic, you know. And so I think we have to really listen and learn and realize that everybody has their own opinion, right? And their own preference on how they want to be referred to. And how they refer to themselves. And that's such a part of it, you know, but when you say, like Dr. Carla, you know, those marginalizing terms, you know, there are terms like wheelchair bound, when in fact, a wheelchair is very liberating. You know, that's how you get to the bar and the ball game and to work and to do, you know, the other things, you know, that you want to do. When we inflect ableism and paternalism, into and racism into, you know, our terminology, those words are harmful. And I was thinking, you know, when Tawara was speaking, to really put this in our list of questions for later, to really talk about how we get better, how we change the system so that young people really identify early on and can own their trajectory. They build, right, that personal agency going forward and that positive, that disability pride that many of us carry with us. You know, and getting to that point, but it's hard, you know, when we're talking about mental health disabilities, you know, and we worked very hard to get rid of the R word legally, because it is that harmful. So I think, you know, throughout this, you know, we can sit here and list off lots of words, but I think throughout this discussion to bring them up and to learn from each other on what those trigger words are and how we create that change to get beyond them.
Absolutely. And to your point, Meryl, I think, you know, Dr. Marco has also a really great perspective that I'd love to include into the conversation. Dr. Marco, can you share your perspective around, you know, identity and choice?
Yeah, so person first language was not something that I understood, or I thought it was, when I did hear about it, I thought it was people being overly sensitive, because in my field we say diabetic or quadriplegic or 55-year-old black male with, you know, so we learn to present that way. We learn to describe the condition with and make it a noun, and so I didn't even understand what the hoopla was around saying person first rather than identity first, and now I do, because it's been brought to my attention, and with the work I do with the Christopher and Dana Reeve Foundation, when you apply for a quality of life grant, if the application includes terminology that is identity first, or identity alone, like quadriplegic or diabetic or hypertensive or paraplegic, then their grant application is not considered. So we're taught to look at that and know that this is a person living with quadriplegia, or a person living with paraplegia, or a person living with paralysis. And all the time, even people within my field, and even Christopher Reeve in his books, he called himself quadriplegic. He didn't use the terminology of person first. He's a person who developed quadriplegia or began living with quadriplegia. And so now the identity first terminology, it does trigger me, because I want to correct them. I want to teach them what I've learned about that it can be harmful without knowing it, and it's privilege blind, because I don't really want to be known as a diabetic now, or a hypertensive, or a quadriplegic. I am a person living with quadriplegia, and I don't want to be militant about it, and I rarely say anything about it, but I have the opportunity to give some lectures and to some physicians and surgeons, and so I will teach them that. Like even, for example, this one lady, she was a wife of a patient of mine, and she was talking to another doctor, and they were talking about my injury, and she said, "Oh, did you hear about what happened to him?" And he said no, and she said, well, he's an invalid. And she was sharing this with me in a very benevolent way. I mean, she was singing my praises with this other doctor, but she didn't know. I didn't correct her. Maybe it would have been optimal for me to correct her, but it's also difficult for me to find the proper way, or no, the least harmful way to teach other people that. And I think sharing stories like that, sharing stories with other physicians who take care of patients with spinal cord injury, and say they're patients with spinal cord injury, they're not quadriplegics or paraplegics, and just letting them know that maybe next time they might think about it, and pretty soon the language may start to become more person first and identity second. For me, it was something that I've learned only since my injury.
Yeah, and so that I have actually had that experience as well, in terms of being kind of categorized or classified as my condition in the presence of healthcare professionals. And just listening to you speak, Dr. Marco, really kind of just makes me think about opportunities for change in education, more so at a systems level. Like, I'm thinking about, how do you train folks who are in medical school when it comes to kind of issues related to language and identity. I mean, I do think that one-on-one conversations are important and helpful. I think this conversation is important and helpful. I don't think that anybody who is on this call right now will move forward within any professional practices, identifying somebody in a way other than person first. But it does make me wonder how we can kind of go about making systems changes when it comes to identity and language. And then, of course, when we think about the whole bias piece as well, is really the highlighting or amplifying the need to engage with people, as opposed to cases or conditions or, even stereotypes.
Yeah, I think Tara, I was gonna send it to you because I know that you have a lot of, experience around institutions and systems and language and, and training. So I'd love for you to jump in here too.
So my first comment is that culture and language are inextricably linked. And if we know about culture and how culture is defined, there are aspects of culture that are passed down from generation to generation, and there are aspects of culture that's constantly changing. And so I think that we are continuing to see different things emerge within language. Again, depending on the person, that identity first, and I've seen identity first more so within a specific disability community than I have in other communities. And I've seen people truly embrace the term autistic and to say, I am autistic. This is who I am. Then we have other people within the disabilities community that says, I'm a person with a disability. And that's how that person may indeed choose to identify. I think what's really important about the language cultural link is how people in medicine are trained, how people in healthcare are trained. And clearly, I put in the chat before that people are their diagnoses. And that's what Dr. Marco is indeed saying. Whereas others are embracing disability full-heartedly as part of their identity. And so I would say that my rule of thumb is what Cynthia said earlier, which is to explore how people self-identify. So that's one thing. Try to do that in interactions with people who experience disabilities, in medical records, in teaching. That is the language cultural link, because that is the only way culture, including the culture of medicine, which is not neutral, it is able to change. And so I think that we are in an evolving space right now within our country, in terms of language. Again, I think I also saw a chat, something in chat about self-identifying as Black as opposed to African American, and also as autistic. And so we have to pay attention to this, be respectful to the people to whom we provide care, and use this aspect that I say is closely linked with cultural competence and cultural humility, that we ask, that we seek our cues from others, so that we can partner in the provision of care.
I think that's so important. And it goes back to, I think, that sort of common theme we all bring, together here, which is listening and finding out what people's experience and what, how they identify, and then how we engage with people that way. And so I think, how we change an entire system for that, and the healthcare system, I think we've talked before, some of us, there's a little bit of, maybe we'll dub it some well-intentioned paternalism sometimes in the healthcare industry. And I mean that, that people, physicians, Dr. Mark, I always like to hear from you on this, and others, you're trained to take care of people, right? And to take care of them and to do for them and to make them feel comfortable. And that doesn't always come with a bias towards, what is the preference of that person? How do they want to be in charge, right, of their healthcare? How they're in charge, and moving the charge back to the person, which is kind of where it should be. And so I do think there's a systemic shift, maybe a seismic shift, but a systemic shift that has to take place. And we kind of have to infiltrate all of the industries to make sure, but particularly healthcare. And so I'd love to, hear from you, Dr. Margot, on how we do that with the rest, with peers, your peers.
Yeah, that's a good question. I was just planning on giving them examples and taking the opportunity to have a slide on that, and when I in the middle of a talk, and hopefully it resonates with them and educate them on what I've been educated on. And maybe even sometimes taking some of them individually aside and letting them know. I think just like he, him, her, they, the pronouns, I think, is finding out what someone may prefer is important. In general, I'm going to take the approach that do the person first. If I do speak with a person or about a person, and then let them correct me if they do prefer that there be addressed identity first. I would rather have that than have them triggered or offended or harmed by me assuming they prefer identity first. I don't think I would usually have the time to ask them what they prefer. I guess I could ask them what they prefer or how they prefer being addressed. I haven't thought about that, but the other thing that when I first got exposed to this is I was trying to be succinct in my writing, and I said cancer patients, and my mentor said it's important to change this to patients with cancer. I was like, well, that's more wordy, that's an extra word, and I don't know why you think this is important, but okay, you're the boss. And now I understand that I was writing identity first, not person first. So patient with cancer is identity first, and he used those words, but I was lost. Identity first, person first. I had no clue what he was talking about, but now I do.
Yeah, I think that, what we're getting at and what we're talking about, and keep, using the term, cultural humility. I think one of the pillars of cultural humility is identifying power structures and how they work. And so even within a context where we may be, a leader in a company, there's also social power, and how that impacts, the work that we do is something that we do have to acknowledge. But another pillar to cultural humility is this self-awareness, right? So doing the work that says, who am I, right? And doing the work that, identifies the areas of privilege that we have, and also the privilege of, doing the work that we do. So, as a provider, I walk into a room and, have power as the therapist, but also acknowledging the ways that oppression and social power, or lack thereof, impact, the way that I might communicate. So if someone says something that might be offensive to me, depending on who they are, the context, I may not actually say anything about that. So if we think about the experience of the other, which is the whole purpose of cultural humility, it's making space for the experiences of other. It says that no matter where we are, if we're on this journey of self-awareness and we know what's important to us and who we are, and to say, it's important to me that I am, a Black woman. And I want to be able to share that, even with my care providers, right? And I want them to acknowledge that not only is that important to me, but it's important to me that they consider that as they are providing me, treatment. And I think, to the point that's in the chat, I think, we also have to be aware of how we word our questions and the language that we use, Because what we're trying to get at, the goal is, who are you? Tell me who you are. How do you do that in your personal relationships? How do you build a friendship that says, I want to know who you are? And of course, these are not, you know, our patients and clients are not our friends, but we can even use the same language. Tell me a little bit about yourself. And the way that a person leads you to understand who they are is you can pick up language, you can pick up, you know, some other information about them, and then identify and be curious about what else is, you know, important for me to know about them. So I might say, you know, I go by she, her pronouns. You know, what are yours? I want to make sure that I get this right. Help me understand, you know, how to say your name. You know, I think racial identity is important. I think, you know, when we're talking about disabilities and we're talking about access, we need to know what's important to that person and who they are so that we make sure the access, so that we do the work to make sure that access is at the forefront of our minds. So, you know, Dr. Marco, I really love that added A at the end of your training, the DEIA. I actually have not, you know, heard about that and would really love to look into. This is the second time you mentioned the mindfulness program that you're in, so I'd love to hear more about that. But I'd really love to kind of move our conversation into the space of medicalization. So there was also a question about Meryl's point of the R word, right? And so I want to, you know, without using the term, because I don't, recognize that a medical term like mental retardation is something that was okay, right? But it has also been shortened. So the R word that Meryl was talking about, if you think about the R word that's in that, it's been shortened and is used socially to talk about, you know, someone in a negative light. And so by, you know, these medical terms being used, I mean, if we talk about mental illness, you know, on social media every day we see, oh, this person is being bipolar, or, you know, I'm OCD, he, you know, like there's this medicalization of terms, but also has these social implications. So, you know, Meryl, I actually want to ask you, because this is something that you made a really great point about, that we were, as we were building this conversation, you know, I want you to, you know, be able to talk about this medicalization of disabilities, but also want to get, you know, some thoughts about the implications of holding this bias in connection with disabilities. And if you can add also the intersection of race. Go ahead.
Oh, sure. Thank you. And please, others weigh in. I think we all work to move away from medicalizing, you know, people's lives. And that comes from when we think of people as, you know, impairments or the problem, or, you know, those of us with disabilities, that we are the problem and we need to be fixed and we are diagnoses. And so it really is when we talk about people and people first and we embrace their identity, you know, then it becomes disability is part of who we are. It is a typical part of who we are. It is what makes us who we are very frequently. And so when we don't, then people's lives become all about, you know, that equation of disability to sickness, and disability doesn't equate to sickness necessarily, right? Disability equates to disability. We want to be healthy with our disabilities. And income disparities, which is also when I, you know, bump over, you know, to Tawara, you know, and some of the others as well, because of the often inequities in our healthcare system. Do people of color get diagnosed as early? Do they get access to equitable treatment? Do they get access to treatment that demonstrates cultural humility, so that we all end up on a trajectory towards, you know, achieving our personal goals and accomplishing the things that we want to be able to accomplish with the supports that are needed to do so. There's probably more to do, and I should bump it over, but gosh, I got to tell you, Carly, you made me think of this when you were talking before about how people talk about disability. And I can't tell you how many times, even today, in the workplace, when I will be struggling, where my ADD is the most manifests itself in anxiety sometimes, like when I couldn't get on that webinar earlier, right? And that anxiety takes over, and they're scatter, like that's what I call it. That's my medical term. I get some scatter there in my thinking, and so I'll say to somebody, gosh, I'm sorry, I have ADD, this and that. So do I. Can't focus on anything. And I'm like, yeah, you really don't, right? But people experience that all the time. People with mental health disabilities, with the stigma that comes around it, when they, somebody will say, gosh, I have OCD and I have to do this. Like, oh yeah, me too. And they give, like a random example, which now, of course, I can't come up with, which would be helpful. But really thinking about how we're responding when people identify with disability, to acknowledge and validate people's disabilities, whether particularly, now I'll switch to the healthcare industry, when people are in a healthcare situation with a provider and they are identifying with disability, or they are talking about particularly chronic pain, people of color and chronic pain dismissed, right? People and chronic pain falls under, the protections of the ADA as well, and, is disability. And so just how are we validating and acknowledging what people share with us, and their disability? And we don't, like, if I had a wish, I have several though, so I'm going to just use this one right here, of not ever having to hear somebody say to me, well, I understand that is tough, and what you experience, with your disability and what you were told, that is a terrible experience, but be glad you're not Black and disabled. If I could people should not have to say that. People should not have to experience that. And that's where we really have just this enormous opportunity through, PCPs, provider networks, every provider, mental health clinicians, and have this, really significant responsibility and commitment to people, right? To level that playing field, to make access to supports and services and healthcare and opportunity more equal. Tawara.
Okay, thank you. I just want to focus a little bit more on language and how important language is. And, we've talked about identity first and person first. And I'd like to share a concept that's not on our list, and that's called disability justice. And it is a framework that was developed by people with disabilities. And I want to share this because I'd like people to think about, what does it mean within the context of healthcare? And by the way, disability justice, both words are capitalized. Disability justice is to cross disability, sensory, intellectual, mental health, psychiatric, neurodiversity, physical mobility, and learning. It's a framework that values access, self-determination, and an expectation of difference. Okay, so that's huge, an expectation of difference. An expectation of difference means that we expect difference in disability, in identity, and in culture. To be included and part of our society is about being able to be our, and this is in quotes, whole self. That's all of our identities together. Disability justice includes a space for self-care, reflection, and hard discussions. Disability justice redefined beliefs about productivity, attractiveness, and the value of human life. And we know during the pandemic, unfortunately, there were so many instances of people with significant disabilities. Someone saying, well, his life's not worth changing, has significant disability. Let's move on. Beyond challenging what is considered normal, disability justice addresses the deeply held fear of vulnerability by practicing the value and act of interdependence. I wanted to share that. It's lengthy, it's involved, but it is clearly an expression and terminology that I'm seeing frequently in the work that we do. And it comes from the space of people with the lived experience of disability. So what might that mean? Self-determination, beliefs about productivity, beliefs about attractiveness, the value of human life. And the expectation of difference. And when we think about that, we're all human beings and we're all different. It again, lastly, reminds me of the definition of disability in the Development Disabilities Bill of Rights Act. And its disability is a natural part of the human experience. Okay, say it again. It's a natural part of the human experience that does not diminish the rights of individuals with developmental disabilities to enjoy the opportunity to live independently, enjoy self-determination, make choices, contribute to the society, experience full integration and inclusion in the economic, political, social, cultural, and educational mainstream. So what does that mean within the context of healthcare? It is a natural part of human life. It's not an aberration. It's not, quote, an anomaly. It is a person who experiences a disability based in the areas, whether sensory, physical, intellectual, etc. I have one other comment I'd like to share. And I have a colleague who self-identifies as autistic, would freak out just hearing the word, and I'll just say a former word, people were referring it to the R word, and feels it as a slur. And was legislation passed years ago that by Congress, not always the most enlightened body, but by Congress, that changed the term to intellectual disability. And there are still people within healthcare arena that use other terms to describe people with intellectual disability. Again, language, again, culture.
Yes, 100%. I was listening so intently, I forgot that I had to chime in. Tuara, that's such a great addition to this conversation, because as I'm talking about and thinking about cultural humility in action, right? There is this justice, disability justice tells us the action of, implementing this, not only for ourselves in our personal life, but also in our work. Cynthia, we talked about this during, our first conversation. So I want to, kind of give a little bit more context here as well. The intersection, and we talked about intersectionality, not just being, multiple or two, in this case, identities that just, meet, right? That we're also talking about, a look at the infrastructure, the systems, the systemic racism, for example, systemic ableism, and the experience of people of color with disabilities. So I want to make sure that we're also, expanding our conversation to how this makes sense, how cultural humility, disability justice, the disparities that we're talking about, social determinants of health, that we're really clear about how the disparity gets more complex. The disparities get complex. I won't say more complex when we include, conversations about race and systemic racism and systemic ableism. How can we continue to, kind of expand and deepen our understanding at those intersections?
Well, if this were a social media post, I'd say it's complicated. I think that, one of the things that we touched on during our last conversation that we really, I'd love to go deeper in, would love to hear the perspective of the panelists, is that we kind of don't talk about how people of color, particularly Black folks, are positioned even within the disability community. There is so much feeling of exclusion, I will say, among my friends who are Black and disabled when it comes to being part of a group, right? Added to that, dealing with our country's history of racism is very challenging. And what's very challenging is that it goes unacknowledged or unaccounted for. I mean, it's almost as though the legacy of racism that we have experienced, people feel as though it does not affect society today just because, well, I did not enslave people, I did not do this, that, the other. But we have to remember that, you know, slavery was a part of our society from what, 1619 to the mid 1800s. But then after that, we had all of these race-based laws that impacted how Black folks were able to, or impeded, I would say, the ability to acquire wealth through home ownership. I mean, you know, Black folks couldn't get loans to buy homes due to redlining. You know, we always hear about the women's suffrage movement, which was very important. You know, women, you know, could only vote for 100 years ago, only gained the right to vote 100 years ago. That was white women. People weren't advocating on behalf of Black folks, right? So I think that it's really important that we also think about our country's legacy of racism as we also think about, you know, issues related to disability and how we are engaging people of color in the disability community and in conversations about, you know, disability rights.
Absolutely. Dr. Marco, you mentioned as you were talking about your experience with the mindfulness meditation training that you are engaged in, that you are also engaged in, you know, kind of this self-awareness and building self-awareness around your racialized experiences at the intersection of, you know, your experiences of, or, you know, as you look at your social location. So I'm wondering if you are okay with expounding a little bit more on that journey and the experience that you're having.
Yes. Well, we started off by separating into different groups, and I was offended. I had to fill out some identification questionnaires, and I was moderately offended that they put me in a group with all Asian people, because I didn't really identify as Asian. So I didn't know where I belonged, actually. I didn't identify as a person of color. So it was really awkward for me. But once we got started, and I realized that there were people in there who were of Asian descent and proud that they were of Asian descent, and there were other people who had the same experience as I did, and did their best to assimilate as best as they could, so as not to stand out. And you know, I remember reflecting back to my childhood that I didn't want to be teased or considered Asian, or made fun of, and kids running around pulling their eyes apart and making them slanted, and saying rhymes that were derogatory. I didn't want that to occur. So that might have been the genesis of and I was embarrassed that my grandparents didn't speak English, and so I really, and I had a mother who I felt tried to fit in and be Americanized. So that self-realization that is who I am and who I became, and that there's a different way, and that the learning more about racism and anti-Semitism, family of origin trauma, and generational trauma. The trauma imparted on the English people on the English people, and then those English people coming over here and imparting trauma on their own people and people of a different race as well. So, you know, a lot of it is also generational trauma too. So we learn a lot about it. We were separated into groups, and most of the people in my other group were, I don't know what the proper term is, but Caucasian or white, and there's a lot of anger and frustration and difficulty expressed around that. There were also people from South America and Europe and Australia, so I don't think they quite understand how different it is here. And they also don't see that it's not great there either, because there are indigenous people there who have lost their land in where they're from. So I don't know if that answers your question, but it's been really eye-opening for me, and every book I had the opportunity to read or listen to, and each group I had is really important to me. We filled out a chart where it was a sunflower, I think, and we listed the things where we were prejudice blind, and it was astounding how many categories of blindness that I fit into. So
Yeah, that many of us do, and I so appreciate your vulnerability. I appreciate understanding, you know, the journey, right? And you know, part of what you're talking about is this you know, consistent desire to not be othered, to belong. And when we're in a society where belonging or the experience of belonging is set aside for certain people, and not all, then, you know, the hope for those that are other, that are marginalized, that feel and are you know, made to feel different and less than, that the hope is that we can get to this experience of, quote, normal. And you know, I you know, as you can see, I could talk forever on that, but I'm interested in, you know, as we begin to talk about centering you know, invisible experiences, you know, people who, you know, are powerless in having agency over even just who they are, you know, being able to name themselves and identify themselves, and be who they are. One term that has really, you know, kind of entered into the DEI space and our language is neurodiversity. And I think that neurodiversity and the question that, you know, we have here is a great example of the disparities and the you know, oppression and marginalization that happens for you know, children of color, especially as there is early diagnosis and intervention. And so, Tuara, I'd really love to get your thoughts about neurodiversity. You know, what is it? But then more specifically, the biases that lead to the disparities in early intervention and treatment when it comes to, you know, autism and other types of neurodiversity.
Let's see, there's something in chat about explaining or defining DEI again. Okay, so I think that we should pay attention to some of those. So I would say that when we think about neurodiversity, it's looking at how we're wired, that we all are humans. we're all cultural beings, and that we don't come here ordered in the same way. I'm using this, I'm going to say more social definition of what neurodiversity is. And it's generally used many times to describe people with disabilities. However, it can be used to describe all of us as humans overall. That's one thing. The second is that even among those who are using the term neurodiversity, there's sometimes a failure to recognize the diversity within neurodiversity. And when I say that, not necessarily only by disability, but by race, ethnicity, gender identity and expression, etc. So as I think about neurodiversity, again, I still will use a cultural lens, because that's really very important, because the experience of neurodiversity for one group or an individual may be totally different from another group or individual based on societal things such as intersectionality, which I feel is imposed because it's how one is one's cultural identities, social identities are viewed, and because of multiple membership in these various social groups, that person may experience harm, discrimination, oppression, marginalization. So again, at least these are my understandings of those terms. When I think about young children, and I'm going to say neurodiversity has largely been used many times on the autism spectrum. So I just want to put that there. It hasn't necessarily always been used across all disability groups. I would say that there's just strong literature that shows that children of color, in particular African American or Black, and also Latino, are diagnosed much later with autism than their non-Hispanic white peers. And so you have to ask why. And, you know, many studies show that parents aren't listened to, that sometimes the implicit biases of the kid's doing okay. You know, you're not that you're making up something, you're making a mountain out of whole, that making a mountain out of, I should stop trying to say these platitudes because I'm not really good at it. You're making a big deal out of something. Parents still get told this, even though there's just a ton of literature that shows that kids who are Black will get diagnosed with autism at 7, whereas kids who are non-Hispanic white will get diagnosed in early intervention, even as early as age 2, compared to their peers of color. And so we'd have to ask why. Some of it is, again, implicit biases. Some of it could be lack of awareness among families, just in terms of seeing developmental trends and what does that mean. And some of it is that no access to early intervention. I think it's a complex array of things that may impact it, but the fact is it's happening. It impacts the lives of children and families across this country, and it is still happening in terms of looking at data overall. So those are my thoughts about neurodiversity, and remembering that there is cultural diversity, racial diversity, ethnic diversity within neurodiversity, and what that all means and how it plays out in the lives of people who experience disability.
Thank you for that. Cynthia, I see that you're moving. I was gonna throw it over to you, but we can wait if you need me to.
Yeah, if you can give me just a second, I'm so sorry. The conference, the folks told me that I could do this presentation up here, but now I'm being told to move. So if you can give me just a second, I think I'll be able to be relocated in a more suitable spot.
Absolutely.
Real life.
Take your time. Meryl, did you want to ask a question? I want to make sure I acknowledge that.
No, I would love to, Dr. Marco, in the meantime, you have been so vulnerable and transparent, sort of about your views about disability and race, a little bit sort of prior to your disability, and to now. And as we kind of are looking, I always think like the last 13 minutes, we need another hour. But as you, look to close, and, we have participants on here and others that will tune in. Thoughts, I mean, things you would share, with people about the intersection of race and disability to change the way people go forward, just in everyday interactions. I mean, you've talked about like how you would train, right, and what you would share and what you're learning, from the mindfulness. But what are those thoughts that come to mind for everyday interactions that providers of all sorts, right, are having with people of color with disabilities?
Well, I think that's a really great question, and a difficult question. I think people leaving the conference were attending a conference like this, having the institutions, like my institution, now has a lot of information on DEIA, and I never even heard of it before the program I entered. So there's so much more on it, and more, and everyone's learning more about it. I don't want to, well, at the risk of sounding better than the program that we have is, albeit it was not perfect because a lot of people had resistance to it, it was very informational, and we I think the more that we talk about it from a place that's healed, from a place that's not an open wound but a scar, then I think that helps, because the times that I was taught it before this it seemed like it was a place from an open wound and not a scar. So when we're being taught when I was taught this time, it was more from a healed wound, or a healing wound, more like a scar. Like Ruth King is one of the authors of Mindfulness of Race, and we learned so much from her, and then we heard her speak, and she doesn't speak from a place of an open wound. She speaks from a place of healing, and I think that's really helpful. So anybody that can move this forward and this speaks to, and wants to, most of us take an oath that says do no harm. If we want to do less harm, and then I think this finding out about diversity, equity, inclusion, and accessibility is less harmful.
I appreciate your point about the self-work that is inherent in being able to make sure that we're not doing harm. There's that saying that hurt people, right? And to not, reduce it to a saying. I want to, explain that, like, if we have our own traumas, right? Our own, personal traumas, social traumas, experiences of oppression that are still in the process of healing, or even in the process of hurting, then part of the work is making sure that when we are engaging with other people, that we're able to separate what is hurting us and to make sense of that and to address it, so that we don't inflict harm, that it's important, even if I feel like I'm rendered invisible in, healthcare setting or from a therapist, right? If that's my experience, if I can't, take ownership of that and learn from it and heal from it, then I'm still going to be, raw and uncut when it comes to the way I treat other people. And so, because we might experience marginalization or defensiveness, even if we don't have experiences of marginalization, if we are defensive, if we are offended because someone is challenging a word that we might say, or our ableism, right? If offense comes up, then we can't actually get to changing it. We're essentially saying we're going to operate from that without actually doing the work of changing it. And so, we have to acknowledge that. Cynthia, I'm really interested in knowing, and a side note, if there are any questions, please, by all means, put them into the chat. There's also the Q&A, and Meryl and I will be happy to address that.
And
Go ahead,
Tara
Tara, I'm
has a
sorry.
question.
Yeah, I don't have a question, but I do want to talk about the space of heal and the space of maybe talking about things from a scar. I think that for things to heal, it takes time, and that that we won't always encounter people who are in the stage of healing. I think that's important for us to acknowledge. So as we look at Ruth King and her work and meditation and things that she's teaching is amazing. I use the term cultural competence. I also use the term cultural humility, and I see that they are. I don't do cultural competence versus cultural humility. I think they both have relevance. So one element of cultural competence is to view behavior within a cultural context. So that means that there are some people who have not reached a place of healing. That may mean that there are some people who still have deep anger. There are some people who have deep hurt, and we have to acknowledge that, actually accept that as we moved toward this journey in terms of racial equity and racial healing, and that some people get over it to a point. Other people do not. And I think that we have to have a lens to understand being able to view behavior within a cultural context, because that's real. And or there are individuals who maybe thought they were healed and they were way along, and then some event happens that takes them all the way back again. So it is a continuum, and it's important for us to acknowledge that.
Absolutely. I appreciate that, that note about, the fact that this is a journey, and it's not steps, right? That's why, humility challenges competence. That's why both are important, as you're saying, that competence gives us this idea that there's just this pinnacle. We just have to get to this goal and then, we're good. Whereas, humility adds in the fact that this is not something that is going to end. This is lifelong, and it is a journey, and that healing too is that journey as well. And we have to be aware of that. And places where we might open wounds, or that we have wounds that get opened on a daily basis, that there are many of us who have persistent trauma that might get healed, and then we live another day. So I so appreciate that. Cynthia, as we begin to kind of close out, I'm really interested in making sense of, kind of a final note, especially for leaders, of people who are decision makers when it comes to these systems. And as Meryl said, these seismic changes, that shifts that we need to make. If we are a leader, whether that be, in our organization or in the work that we do in some way, what should we be walking away making plans to do to challenge this?
That's an excellent question. I would, first of all, really underscore the importance of centering people, asking questions. I love the conversation about context in terms of understanding the context and where other folks are coming from. And I would also say, think about what you want your legacy to be. I mean, at the end of the day, if you are a leader in an organization, the decisions that you make are going to have a long-lasting impact on individuals. And I mean, it's also a matter of, are you upholding systems of oppression? Are you just being complacent, or are you helping to dismantle them? I mean, you really have a choice here. And to me, it just goes back to, what do you want your legacy to be?
I love that. I love that because, part of, if people don't think about their legacy necessarily, because a lot of people don't, right? So I love, kind of putting that out there. But part of that is, where are we leaving the world, right, for generations to come? We feel like we're backsliding right now. So are we breaking those barriers, and are we doing what we need to do as leaders, as colleagues and allies and friends, to create different paths and opportunities and to change the direction? Right. So I love putting that out there at the end like that. I'd love, to hear it, Tawara and, Rex, Carla, what others feel about that. But what kind of a call to action, right, that we can sort of close out on?
Absolutely. We ended our last conversation with a call that we need to continue this particular kind of topic, that we don't see enough opportunities to talk about the intersections of race and disability, and that even conversations about disability, when we talk about inclusion and belonging, are often invisible. And so we challenge ourselves to make space and to continue to make space. Tawara, Cynthia, Rex, Meryl, I so appreciate your partnership in having this conversation and being so vulnerable and willing to, kind of express the journey that we're all on, that takes us in places that we're doing things, quote unquote, right, and places where we need to learn to do better. So I appreciate your challenge. I'm so grateful to all of you. And I hope that you enjoy the day in your part of the world. Thank you all for being here as well.
Thanks, everyone. Thanks, Dr. Carla.